publish journal articles and handbooks in her fields of expertise. Next, our second speaker is no less than the president of the Philippine Thyroid Association, Dr. Nemencio A. Nicodemus, Jr. Dr. Nicodemus is an esteemed biochemistry professor from the University of the Philippines College of Medicine and a clinical professor of endocrinology in the Philippine General Hospital.
Arnel, you are on mute.
Yes, sir.
Are you done with your introductions already?
Done with intro?
Yes.
Okay.
Did the introduction come across?
It wasn't finished, but it's okay. We can start with
Okay,
our
sir.
first lecture already.
Okay, sir.
Okay, good afternoon, everybody. Let me just hide my video. Can you hear me?
Yes, yes, we can hear you.
Sandali, off. I'm sorry, I think I have to switch off my video so that they can hear me well. All right, so good afternoon, everyone. In behalf of the Philippine Society for Reproductive Medicine, we would like to thank the organizers of this afternoon's lecture series. I would like to congratulate you already. I heard that you have almost 800 registrants for this activity. Now, for the lecture this afternoon, for my part, I am supposed to talk about the role of hormone interaction in the normal female reproductive physiology. Therefore, this short lecture comes in two parts. Actually, I can just finish it with one slide. I was telling Dr. Nicodemus. When we talk about the normal physiology of the female, there are two requirements as far as the female is concerned. Now, the hallmark of a very good reproduction for the female is ovulation and menstruation and or pregnancy. And for the woman to achieve that, then she will have two requirements. The first requirement is an intact hypothalamic pituitary ovarian axis, and of course, a responsive uterus. The hypothalamus and the pituitary gland will stimulate the ovary, and when the ovary ovulates, then this is the hallmark of an intact female reproductive physiology. The ovary, after ovulating, will wait until it becomes pregnant. But for that to happen, the hypothalamus and the pituitary gland will be working together. It is initial that the hypothalamus will be secreting a gonadotropin-releasing hormone. The gonadotropin-releasing hormone is a decapeptide, and it is quite unique because among all the releasing hormones coming from the hypothalamus, this is the only one that will be regulating two hormones, two gonadotropins, the FSH and the LH. Initially, at the first part of the cycle, the GnRH will be stimulating the release of the follicular stimulating hormone. This follicular stimulating hormone, as we very well know, will be targeting the ovary. specifically the ovarian follicle, so that oogenesis can happen. And with the growth of this ovarian follicle will now be producing an important sex steroid hormone, and that's going to be estrogen. This estrogen, ladies and gentlemen, will be sensed by the higher center. And with increasing estrogen, the pulses of the GnRH will now be altered. And because of the alteration of these pulses, then the second gonadotropin will now be released. That's going to be the luteinizing hormone. So estradiol peak is followed by LH peak. And with LH peak, this will now act on the chosen follicle, the mature Graafian follicle, and this follicle will now ovulate. With ovulation, the egg cell will continue its growth, and while it is growing, it will be caught by the fallopian tube, and in the fallopian tube, it's going to wait for that lucky sperm cell to fertilize it. Now, while waiting for the fallopian tube, the corpus luteum will now continue its growth. Aside from secreting estrogen, this corpus luteum will also be secreting progesterone. Both the sex steroid hormones will now be acting on the uterus so that uterus will be prepared for a pregnancy. Now, on the first part of the cycle, it is estrogen that will be stopping the menstruation. Why? Because estrogen will be stimulating the growth and the proliferation of the endometrium. Eventually, when the growth and the proliferation becomes good and the estradiol peak is reached, then estrogen will now stimulate LH peak, and with LH peak, there's going to be ovulation. And with ovulation, both estrogen and progesterone will now be working on the endometrium so that this endometrium will become vascular, secretory, and is now ready to accept a blastocyst should the woman become pregnant. If the woman does not become pregnant, then there will be luteolysis, or death of that corpus luteum, with withdrawal of the sex steroid hormones estrogen and progesterone, thus causing withdrawal bleeding or menstruation, which I usually call the cry of a frustrated womb. But should the woman become pregnant, then the human chorionic gonadotropin coming from the pregnancy will prolong the life of the corpus luteum, preventing luteolysis, and estrogen and progesterone is continued to secrete until the placenta takes over. Now, it seems to be very simple as far as the female physiology is concerned. However, it is important for a gynecologist or a clinician to understand that there are other hormones. Yes, there are other hormones that will be influencing everything from the hypothalamus to the pituitary gland to the ovary. So we talk about this. These other hormones presented clinically will affect the woman's ability to menstruate regularly, will affect the onset of the woman to have menstruation, even affect the pregnancy outcome of these women. The key is the GnRH pulses. This seems to be very busy, but I would like to just advise the clinician to just remember this graph. As you can see in this graph, during the follicular phase, the rate of secretion of the GnRH is faster at 1 pulse per hour compared to the luteal phase, where it is secreted at 1 pulse every 2 to 3 hours. And the difference between the early follicular phase and the late follicular phase is the fact that in the mid-follicular or late follicular phase, it is a little bit faster than usual. Why? These changes in the GnRH secretion gives its ability to control whether it's going to be for FSH or whether it's going to be for LH. And theoretically, you can see here, short pulses, okay, faster but lower pulses will now stimulate FSH. And these pulses here in the mid-follicular or the late follicular phase is the one also that will be accentuating the release of the luteinizing hormone. Now, there are several endocrinologic events that are associated with the growth of a child. The initial endocrinologic event associated with the onset of puberty is the episodic pulse of LH. That should happen first. And the last thing that we are waiting for would be the positive feedback mechanism, the positive feedback of estradiol onto the gonadotropin LH. So in other words, the last endocrinologic event of puberty would be estradiol peak followed by LH peak. That's what we're waiting to mature. And initially, when the child goes through puberty, it takes around 2 to 3 years for this positive feedback to mature. Therefore, what is now the key in the pulse frequency of the gonadotropin releasing hormone? Several studies has been done and two mechanisms have been implicated. One, they say there is an inherent pacemaking activity of the arcuate nucleus itself. It's just like the pacemaker of the heart. Now, if there is an inherent pacemaking activity, there is another substance that has been implicated, and that is kisspeptin. This kisspeptin is secreted by KIS1 neurons, and this directly stimulates the GnRH neurons. Therefore, it is postulated that the kisspeptin is the one that would be stimulating the pulses as well. Now, this kisspeptin does not only activate or innervate the GnRH, but it is mentioned that this is the one that will mediate the sex steroid feedback loops, especially the positive feedback loop. And this KIS1 is also postulated to play a role in the initiation of puberty. What happens? So what do we have here? We have here the kisspeptin secreted by the kisspeptin neurons, and this will now act on the hypothalamus, specifically the KIS1 receptors in the arcuate nucleus. And once the arcuate nucleus is stimulated, the GnRH will now be secreted, and it will be secreted in pulses, as we would very well know. So this hypothalamic pituitary ovarian axis is intact. Children are born with an intact HPO axis. So the question now is, how come children do not menstruate and they suddenly menstruate during puberty? They say initially when a child is young, prior to puberty, the hypothalamus, they say, is very sensitive to levels of estrogen, such that even low levels of estrogen is enough to inhibit the hypothalamus. That's why there is no breast development, there is no uterine development during childhood. However, in puberty, the hypothalamus suddenly escapes that sensitivity from estradiol. And what caused that escape, they do not know, but they have implicated kisspeptin and leptin. They say leptin modulates the kisspeptin and the KIS1 receptors, thus it will stimulate earlier menarche for children. That's why this leptin, okay, and it is, they say, important. That's why in gynecology we say that for a child to achieve puberty, the child must have a critical fat level. And evidence suggests that the leptin modulates the kisspeptin receptors and the kisspeptin itself so that it will influence puberty. That's why comparing children who have a adequate fat and those with normal body fat, children with higher body fat will have higher leptin levels, and with higher leptin levels, the gonadotropin releasing hormone secretion pulses will be achieved by the modification of the leptin with the kisspeptin, and eventually there will be secretion of the gonadotropins. These two gonadotropins will now stimulate oogenesis. There will now be sex steroid hormone production, and she will now ovulate. Contrary to children who are rather thin, children or prepubertal child who are thin will have lower levels of leptin, and because there are lower levels of leptin, GnRH modulation does not happen, no LH, no FSH, and she does not ovulate. This is also the reason why leptin has been implicated in reproduction. Anorexic women do not ovulate. Why? Because with anorexia, low leptin, no GnRH pulses, no ovulation. All sex steroid hormones will be low. On the opposite, if a woman is overweight, obesity, okay, which is usual in PCOS women, obese women will have high levels of leptin, and high levels of leptin will now also inhibit. You see, that's ironic about a woman's HPO axis. She wants hormones, but too much of a hormone is bad, and too low of a hormone is bad. The same thing is true for leptin. The hypothalamus wants leptin, but not too much of leptin, because too much and too low leptin levels will now alter the pulses of the GnRH. This time, in women with polycystic ovarian syndrome, it is not the decrease in the LH and FSH that's going to happen. There will now be an increase in the luteinizing hormone. Therefore, the hormonal milieu of these women will be hyperandrogenic, hyperestrogenic with no progesterone. Okay, so does the thyroid hormone affect the GnRH? Yes, the thyroid hormone is quite unique. This is also a steroid hormones, and I love steroid hormones because compared to polypeptide hormones, these steroid hormones go straight to the nucleus and attaches to the nucleus and influences everything. The thyroid hormones has been implicated in the neuroendocrine regulation of the GnRH, specifically, okay, in Kispeptin. Why? In rats and rodents, they have shown that the T3 would stimulate the gene expression of KIS2 and GnRH1, which is the equivalent of KIS1 and GnRH in humans. Of course, they haven't done that, okay, in vitro for human studies, but they have seen an association between hypothyroidism and inhibition of the Kispeptin neurons. And when the Kispeptin neurons are inhibited, thus, these patients will have no ovulation. So that's the thyroid hormone affecting the Kispeptin. There are other modulators. There are other substances that would affect the secretion of the GnRH. Remember, we said this has to be secreted in pulses, and several other modulators have been identified. The sex steroid hormones, estrogen and progesterone, will modify the GnRH secretion. Neuroepinephrine and neuropeptide Y, also glutamate, will stimulate GnRH, and GABA, dopamine, and beta endorphin, and even corticotropin releasing hormone will inhibit. Therefore, as a clinician, anything that will alter the levels of all of these hormones will alter the stimulation of GnRH. Okay. We say, as far as the two sex steroids are concerned, estrogen will decrease GnRH, progesterone will increase GnRH. So for our young clinicians, that's going to be very tough to memorize. Just remember again this graph, refer to this graph. If you know that in the follicular phase, the dominant hormone is estrogen, and in the luteal phase, the dominant hormone is progesterone, and you remember this graph, you know that estrogen will decrease the amplitude of the pulses of the GnRH, whereas progesterone will increase the amplitude of the pulses of GnRH. Okay. If you would look at several literatures, the thyroid hormone has been implicated in all parts of the reproductive system of a woman, from regulation of menstrual control, even to lactation. Now, does this affect also the different parts of the reproductive system? They say the thyroid hormones have effects, okay, in the reproductive system for two reasons. Number one, it directly acts on the reproductive organs. In other words, it doesn't just act on the hypothalamus, it also acts directly on the uterus, the fallopian tube, even the placenta, as we will later try to see. Now, these thyroid hormones also affects the female reproductive system because it affects the bioavailability of hormones and growth factors that are necessary in normal functioning. Growth factors, when is this important for a woman? For folliculogenesis, we know that the development of the follicle comes in two stages. It's either gonadotropin dependent or gonadotropin independent. In the first part, from the antral follicle, it is gonadotropin independent. So what stimulates the growth of these follicles would be several growth factors. Therefore, we see how powerful the thyroid hormone is and how powerful, how important it is in the female reproductive tract. Okay, we said the thyroid hormones will directly affect the sex steroid hormones, estrogen and progesterone. And how does it do that? The thyroid hormone in several investigations has been shown to affect the bioavailability and metabolism of sex steroid hormones. Second, it also affects the hepatic production of the sex hormone binding globulin, which we very well know is the transport protein of the estrogen, testosterone as well, not progesterone. So just summarizing, coming from all the studies of these researchers, I tried to divide the effect of hypothyroidism and hyperthyroidism in the hormones. So you can see generally for hypothyroid women, beta estradiol, 17 beta estradiol is low compared to hyperthyroid women. And they say high levels of estradiol in hyperthyroid women is secondary to the decreased clearance of 17 beta estradiol and the increased conversion from androgens. In other words, it will now cause aromatization of these androgens, thus increasing levels of estrogen. In hyperthyroidism, it is also noted that androstenedione and testosterone are also elevated. Therefore, it favors the formation of estrogen because all of these androgens will now be aromatized to become estrogen. The only thing that is low in hyperthyroid women, consistently low, whether it's hypo or hyperthyroid, is the metabolic clearance. So in other words, for hyperthyroid women, we have high levels of estrogen, we have high levels of testosterone, plus, look at this, we have high levels of sex hormone binding globulin. So generally, what's going to be the effect? Okay, sex hormone binding globulin is the binding globulin of our sex steroid hormones. It loves both estrogen and testosterone. However, it has a favorite. Between estrogen and testosterone, the favorite of the sex hormone binding globulin would be testosterone. Therefore, if you have high levels of estrogen and high levels of testosterone, high levels of sex hormone binding globulin, the net effect is that the testosterone will be bound to it first. Therefore, there will be lesser free testosterone, and whatever free testosterone you have, it will be aromatized and converted to become estrogen. Therefore, hyperthyroid women, they say, is estrus. There's a lot of 17 beta estradiol. Okay, literature reports have shown also the effect of these thyroid hormones on the sexual behavior, meaning the onset of menstruation and the incidence of ovulation. It has been mentioned that if a child is hyperthyroid prior to puberty, then her menstruation will be delayed and there will be a lot of anovulation. If the child is hypothyroid at any day, then there will be delays in sexual maturity, and so, this is conflicting, okay? Because some reports would say hypothyroidism is associated with delays in sexual maturity. Some literature would say hypothyroidism is associated with precocious puberty. The reason for the conflicting effect, they say, has something to do with other hormones, specifically leptin. Okay. We also said that the corticotropin-releasing hormone is also another modulator of the GnRH. So when do you have CRH? Now we have a lot of stress because of COVID. That's why I don't like to exercise like these women. I might have a lot of CRH and I will not ovulate, right? But then again, this is the reason why stress can affect menstruation for our women. Therefore, you have to see first if she's under stress or not, okay? Another modulator for the GnRH pulses would be prolactin, and we are all very familiar with this. We have known that breastfeeding increases prolactin. So any other condition that would increase prolactin would do the same thing. High levels of prolactin will inhibit the activity of GnRH. And when you have inhibition of the pulses, you will have no increases in LH and FSH, no estrogen, no ovulation. Well, there is some estrogen, but the estrogen is low because the FSH here is very, very low as well. Why? The purpose is so that this calcium will be out to the serum, will go to that fetus. Now, therefore, prolactin will also affect it. However, okay, how does prolactin do that? They said prolactin inhibits the GnRH pulses by affecting the kisspeptin neurons that we earlier mentioned. So, ang dami naman palang influences. How about the thyroid hormone? The thyroid hormone also influences prolactin. evidence have shown that hypothyroidism increases the levels of prolactin. In fact, 22 to 57% of women with hypothyroidism, whether clinical or subclinical, have also an associated hyperprolactinemia. They say TRH stimulates the lactotrophic cells. Now, TRH seems to be very powerful. It is just composed of 3 amino acids, but it will now stimulate also the lactotropic cells in the pituitary gland. Thus, it will stimulate prolactin secretion. So now you see there are several hormones that would be acting on the central nervous system. Stimulatory, inhibitory, all of this will now affect the pulses of the GnRH, thus eventually affecting the hypothalamic, pituitary, ovarian axis. So summarizing only the effect of the thyroid hormones both on GnRH and LH, if the thyroid hormones are very low, hypothyroidism, they say, is associated with failures in the occurrence of LH peak. So no LH peak, no ovulation. There will be reduction in biosynthesis of GnRH, so no pulses, no FSH, no LH, and the thyroid hormone itself will also cause hyperprolactinemia. Therefore, clinically, if you have a patient who has hyperprolactinemia, you don't just look at hyperprolactinemia itself. You must investigate also because of an almost 50% association with thyroid disorders. Because if you just treat hyperprolactinemia, then you might not be successful. Okay, so GnRH pa lang yun. We now go to the second level, which would be the pituitary gland. Now, physiologically, during the lifespan of the woman, the FSH release is high during childhood, prior to puberty, and during the menopause. Therefore, there is a preferential inhibition of FSH. This preferential inhibition is secondary to estradiol and another substance inhibin. Therefore, it is not just estrogen, testosterone, and progesterone. We have another substance here, another hormone, which is inhibin, which preferentially inhibits the release of FSH during the reproductive years. Therefore, physiologic secretion of FSH and LH are altered as well. Why is it important that we have physiologic secretion of FSH and LH? Because these hormones will stimulate oogenesis. It will also stimulate ovulation. If there's no physiologic secretion, then we are in trouble. Now, what hormones interact that affects the pulses of FSH and LH? GnRH, obviously. Decreased frequency will decrease LH and increase FSH. Dr. Alenzuela, it's very difficult. Remember that pathway, okay? If you have a decreased frequency, it will decrease the LH. Annabelle, how come it's going to increase the FSH? Remember, in gynecology, FSH does not start to increase in the follicular phase. FSH begins to increase in the late luteal phase, so that when the woman enters the next follicular phase, FSH is high already. Now, FSH and LH are also stimulated or affected by estrogen. Nakakalito na naman because the effect of estrogen depends on the level. If estrogen is low to moderate, it will decrease LH and FSH, but the decrease is more marked for FSH. Higher levels of estrogen will increase LH and FSH, but more for LH. This is the last endocrinologic event of puberty. The positive feedback of estradiol on the increases in LH, which will cause ovulation. Estradiol peak followed by LH peak followed by ovulation. We are all too familiar with other growth factors that will also influence the FSH and the LH release. Therefore, we must understand what conditions that will affect them as well. Okay, another thing, okay. FSH and LH. Annabelle, are these all sila lang ba? Are these the only ones who will affect FSH and LH? Let us look at the structure of FSH and LH. Identical alpha subunits, different beta subunits. However, it's not just them. There are 4 hormones that are structurally similar to each other. FSH, LH, TSH, and human chorionic gonadotropin. And as you can see here, between FSH and LH, TSH is actually more structurally similar to FSH because they are both composed of 112 amino acid, 112 amino acids, so the difference is only 1 or 2 amino acids. What does this mean? Because they are similar, if you have high levels of TSH, this will be misinterpreted and can be misinterpreted as FSH in any area that FSH and LH is supposed to work. And therefore, it will affect the pulses. Okay. This thyroid hormone similarity with FSH and LH will affect folliculogenesis. Okay. We said that there are several factors that will affect folliculogenesis or oogenesis. We have growth factors like interleukin, cytokines that will stimulate the gonadotropin-independent growth of these follicles. However, okay, in the gonadotropin-dependent, then there will be the effect of both FSH and LH. We all are familiar with the two-cell-two gonadotropin theory. However, studies have shown that the oocyte, the granulosa cell, even the ovarian stromal cell, and the cumulus or ovorus have receptors for the thyroid hormones T3 and T4. These cells also have the enzyme deiodinase. So what does it mean, Dr. Alenzuela? In biochemistry, the principle, as long as there is a receptor, that cell is a target cell, even if you do not know the biologic activity. It is quite difficult to study the ovarian follicles. However, there are some researchers who have done and who tried to combine FSH and T3. And in this in vitro studies, they have shown that the combination of FSH and T3 will enhance proliferation of the granulosa cells, reduce apoptosis, even stimulate aromatization in the granulosa cell. And in the theca cells, it will inhibit excessive production of androgens. Looking at all of these activities of the thyroid hormone on the follicular cells, this tells us that this will stimulate folliculogenesis. Now, they have observed that among women who have hypothyroidism, the number of the growing follicles has been affected. It has been reduced, and follicular atresia is stimulated. They postulate that this is because of the effect on the thyroid hormones on the GnRH-LH axis. The thyroid hormones also affect the kisspeptin and the sex steroid hormone production. That's going to be estrogen and testosterone and progesterone production, and also thyroid hormone increases also the prolactin levels, which we discussed earlier. And with this decrease, ladies and gentlemen, then we see follicular atresia rather than follicular growth. The thyroid hormone does not only affect folliculogenesis or oogenesis, but it also affects the life of the corpus luteum. We don't want that corpus luteum to die early, causing luteal phase defect, or to be prolonged, causing a cyst, okay? But they have noted that in women who have hypothyroidism, this has caused prolongation of the life of the corpus luteum. Why? Because it suppresses the catabolism of progesterone. Okay, so when you have low levels of T3, T4, progesterone catabolism is suppressed, then the life of the corpus luteum is prolonged. On the other hand, with women who have hyperthyroidism, this may cause luteal vascularization. Okay, coming to my last few slides. The all-too-powerful thyroid hormone does not only affect the corpus luteum, the ovary, the higher center, but the second requirement. Remember, for a woman to have normal menses, she has to have an intact HPO axis, and she needs to have that uterus, and she needs to have that fallopian tube. The thyroid hormones also affect the uterus and the fallopian tube, okay? And research have shown that abnormalities in women with abnormalities in the thyroid hormone levels of some women is responsible for spontaneous abortion, intrauterine growth restriction, preeclampsia, and preterm labor. This will be discussed further in the next session of this thyroid hormone series, okay? Why? Because they said thyroid hormones regulate the responsiveness of these organs unto the hormones. How does it regulate? Number one, T3 and T4 will modulate the responsiveness of the uterus to estrogen, and it will also stimulate endometrial vascularization and decidualization. Therefore, if there is an abnormal level of the thyroid hormone, then these two steps will be affected, thus causing failure or accidents in pregnancy. Okay. Eventually, the end of the day, when a woman is hypothyroid and she will have low levels of estrogen, these low levels of estrogen will reduce the volume and the height of the epithelium, with reduced nuclear volume in the uterine epithelium, will thicken the basement membrane, reduce the villous height of the infundibulum in the fallopian tube, and reduce the number of size of the villous lining of cells. That is why they say it will affect pregnancy. And the last step that the thyroid hormones will affect will also be implantation. Why? Because studies have shown that thyroid hormones will also influence the differentiation and the migration of the trophoblasts, and it will also influence the endocrine, angiogenic, and immunological activity of the trophoblasts. It is essential so that all these three activities will be done by the trophoblast for successful invasion of that endometrium so that implantation will happen. Therefore, if any abnormality in the thyroid hormone will also affect all of this. Okay, so finally, I have come to my last slide. I hope I was able to help you. I talked about the role of hormone interaction in the normal female physiology. For a woman to be a complete woman, two things must come: an intact HPO axis and an intact uterus. A uterus that will respond to the hormones that are produced coming from the ovarian follicles. For a woman to be successful in reproduction, the key is the pulses of the GnRH. With the pulses of the GnRH comes the growth of the follicle, and the second thing that's important is estradiol peak, followed by LH peak, followed by ovulation. So in all of these parts, there are several hormones that will affect the higher center, the GnRH, several hormones that will affect the pituitary gland, even the ovary, even the uterus itself. And it is quite unique because the thyroid hormone affects all of this, thus causing all of this effect in the ovary, the uterus, and the placenta. That will be discussed by our next few speakers. Maraming salamat.
Thank you, Dr. Alenzuela. We would just like to remind our attendees to type your questions and comments in the Q&A and chat boxes for the open forum after the two lectures. Now we will have Dr. Nicodemus' lecture.
Good afternoon, everyone. I would like to thank Dr. Alenzuela for clearly elucidating a lot of the physiological concepts and the hormone interactions in a woman's reproductive function. For my part, since this particular webinar has three objectives, the first one was already discussed to us by Dr. Alenzuela. My part will be to explain the effect of thyroid dysfunction in female fertility and to describe the management of thyroid dysfunction as the cause of female infertility. Of course, when we talk about infertility, this definition always comes to mind. It is, of course, that disease of the reproductive system defined by the failure to achieve clinical pregnancy after 12 months or more of regular, unprotected sexual intercourse. And whenever we talk of causes of infertility, it is always partly female, partly male. And we all know that both contribute to the causes of infertility. When we talk, however, of the causes of female infertility, the most frequent causes still are made up of ovulatory disorders, endometriosis, pelvic adhesions, and even tubal blockage and hyperprolactinemia, as already mentioned by Dr. Alenzuela a while ago. One thing that's not here, although a lot of women have this, and may cause or be partly the cause of subfertility may be the polycystic ovary syndrome. How often do Filipino men and women develop thyroid disorders? Fortunate for us, we were able to come up with the Philippine Thyroid Disease Study, which looked into the prevalence of thyroid disorders among adults in the Philippines. And although this has been published a few years back and will need revision and, of course, revisiting of the data, this is the first data that we have that will give us an almost nationwide idea as to how prevalent thyroid diseases are in our country. And based, of course, this particular definition of thyroid disorders is hinged on the fact that there is a very intact relationship between the hypothalamus, the pituitary, and the thyroid, much similar to the axis to the ovary that was already described to us by Dr. Alenzuela. We know that the hypothalamus secretes the thyrotropin-releasing hormone, or your TRH, which has a positive influence on the anterior pituitary. The anterior pituitary, therefore, releasing now your TSH, or your thyroid-stimulating hormone, otherwise known as thyrotropin. This particular thyrotropin now, of course, exerts this effect on the thyroid gland for the gland to release the thyroid hormones T4 and T3. But we also know that this particular axis is vulnerable to the negative feedback mechanism, such that if you have excesses in your T4 and T3 that are released from the thyroid gland, it exerts a negative effect, suppressing now the release of the TSH from the pituitary and suppressing the release of the TRH from the hypothalamus. And therefore, your T4 and T3 are very important hormones that exert this negative feedback. Having said that now, what happens is that if you have very low levels of your T4 and T3, it now, of course, is not able to exert a negative feedback and will now cause an increase in your TSH. And therefore, that's the best way to recognize hypothyroidism. You have elevated TSH, whereas in hyperthyroidism, because you have an excess of your T4 and T3, your negative feedback is very much at work and therefore your TSH is low. But there are several permutations of the combination of the TSH, the FT4, and the T3. But just to review everyone, if everything is within the normal reference range, then that patient is considered euthyroid. But if you look at the TSH and the TSH is below the lower limit of normal, the next thing that you have to consider is the level of the free T4 or the T3. And in patients wherein the TSH is below the lower limit of normal and the T4 and the T3 are above the upper limit of normal, then you have overt hyperthyroidism. But just to illustrate here that you have other possible conditions wherein your TSH is below the lower limit of normal. But if it is accompanied by T4 and T3 that are within the reference range, then that is what we call a subclinical hyperthyroidism. And in cases wherein it is only the T3 that is elevated on the background of a suppressed TSH, that is what we call as T3 toxicosis. So again, you can see that hyperthyroidism is very much characterized by suppressed or very low levels of your TSH. On the other hand, if your TSH is above the upper limit of normal, then consider probable overt hypothyroidism if your T4 and T3 are below the lower limit of normal, and if both are within the reference range on the background of elevated TSH, that is what we refer to as subclinical hypothyroidism. Now, why did I have to describe to you these different conditions? Because they were part of the national survey that we did. We looked at overt hyperthyroidism, subclinical hyperthyroidism, overt hypothyroidism, and subclinical hypothyroidism in the Philippine population, and of course, even the euthyroid population. And what did we find out based on our survey? That the most majority of the Filipinos are actually euthyroid, 91% have normal thyroid function, but you can see that 9% have thyroid dysfunction. And the most frequent thyroid dysfunction is subclinical hyperthyroidism, followed by subclinical hypothyroidism. Again, remember that these two conditions are characterized by normal levels of T4 and T3, and their only abnormality is the TSH level. But you can see here that overt hyperthyroidism is found in 0.61% of the Filipino adult population, and true hypothyroidism is found in only 0.41% of the Filipino adult population. That is good for us because we know, as mentioned by Dr. Alenzuela, that abnormalities in thyroid hormones do exert negative effects, particularly on female reproductive health. And so, among the survey that we did, how many of the population actually had problems with thyroid function between men and women? Clearly, you can see here that true hyperthyroidism, true hypothyroidism are more frequent among women compared to the men in our population. And that is true even for the subclinical thyroid disorders. In fact, there is a 3:1 ratio of thyroid disorder among between men and women in the Filipino population, with more frequent women affectation based on this particular survey that we did. Having said that now, what now will be the effect of this particular prevalence of thyroid disorders among infertility in women in the Filipino population? Of course, as mentioned by Dr. Alenzuela, you can either have a hyper-functioning thyroid or a hypo-functioning thyroid. And studies have shown, at least cross-sectional data, was able to show that among people with Graves' disease and Hashimoto's thyroiditis, which will present to you as hypothyroidism. So we have two extreme cases here, hyperthyroidism due to Graves and hypothyroidism due to Hashimoto's thyroiditis. Infertility was seen in 52% of women with Graves' disease and 47% of women with Hashimoto's thyroiditis. Quite very large numbers, almost half in both cases are affected by infertility. And the reason for the hyperthyroid state is that the hypothyroid state is that the TPO antibody is also highly associated with infertility. In fact, the relative risk of developing infertility in a woman with elevated TPO antibody is actually more than 200% increased. And that is how grave the problem of hypothyroidism is, particularly the presence of TPO antibody in the workup and the treatment of the infertile couple. Why is it that the thyroid can exert an effect on the female reproductive health? And as mentioned by Dr. Alenzuela, any hormone in the body will act on a cell as long as it has its receptor in that particular cell. And clearly, based on studies, immunostaining of the ovarian surface epithelium revealed that it contains receptors for the thyroid hormone. So not only is it responsive to FSH and LH, as mentioned by Dr. Alenzuela, the thyroid hormones themselves have their own receptors in the ovarian surface epithelium, and that is the reason why TSH and even thyroid hormones may participate in the regulation of ovarian function as measured here by the cyclic AMP in cultured human granulosa cells after TSH treatment, and by the kinase activation in cultured human granulosa cells after thyroxine treatment. So indeed, the thyroid and the ovary and the female reproductive system is highly intertwined. And that's the reason why this particular interaction with the thyroid may affect human reproductive health, particularly in females. And that is the reason why whenever we discuss the symptoms of hyper and hypothyroidism, even if we do discuss several of these signs and symptoms that may, of course, include weight loss, goiter, frequent bowel movements, of course, palpitations and tachycardia, what we of course always say among our female patients is that with hyperthyroidism, they may present to us with menstrual irregularities and even impaired fertility. And this has already been alluded to by Dr. Alenzuela during the first talk. How about hypothyroidism? If they will present to you oppositely with progressive weight gain, bradycardia, of course, deepening of the voice, slow heartbeat, there's one thing common between hyper and hypothyroidism in that they also will present to you with menstrual irregularities and even infertility. And the physiological explanation for this has already also been elucidated to us by Dr. Alenzuela. Now, just to give those synopsis of the different hormonal changes that happen during hyperthyroidism and hypothyroidism, it's not just the men, as you can see in this table, but women are also very much affected in that in hyperthyroidism, majority of these is increased. Sex hormone binding globulin, estrogen, estrone, and even testosterone, as already discussed by Dr. Alenzuela, and even your androstenedione and the androgen conversion to estrone is also increased. On the other hand, hypothyroidism, which is characterized by, of course, reduction in thyroid hormone levels, is also characterized by reduction in sex hormone binding globulin, estrogen, estrone, and also a decrease in your LH and FSH. So the two are almost quite paralleling each other. Thyroid hormones, if you increase, like in thyrotoxicosis, these hormones will also increase in the females. In hypothyroidism, a reduction in the thyroid hormones will also cause a reduction. So they're almost paralleling each other. And that will now, of course, lead to certain abnormalities, particularly menstrual disturbances that are associated with thyrotoxicosis and hypothyroidism. The most common menstrual disturbance in patients with hyperthyroidism are your oligomenorrhea, and in recent studies, there are also increases in abnormal menstruation. In hypothyroid patients, the most common abnormality would be the disturbances that you see earlier on and even irregular cycles in the more recent studies. And so indeed, both hyperthyroidism and hypothyroidism lead to an increase in infertility rates because of the menstrual abnormality seen in these two disorders. One other thing, perhaps not directly related to menstrual disorders, is the fact that hypothyroidism can also contribute to the problem of polycystic ovaries. As mentioned by Dr. Alenzuela, primary hypothyroidism increases the TRH, and this now increases prolactin levels. And with increased prolactin levels, you have a reduction in the frequency of your GnRH, an increase in your FSH relative to LH, and increases in your adrenal DHEA. The increase in the TSH here as a result of primary hypothyroidism has a spillover effect on the FSH receptors. And these now will also aggravate the in the presence of polycystic ovary, again contributing to higher infertility rates. Now, how then do we deal with such patients? Having said that hypothyroidism and hyperthyroidism have effects on fertility, what can we do as clinicians to help our patients? In 2017, the American Thyroid Association came up with its guideline on the management of thyroid disease during pregnancy and postpartum, but there is a section here wherein they also discussed the effect on the fertility prior to pregnancy. And one very important recommendation that came out from this guideline is that we must evaluate serum TSH concentration in all women seeking care for infertility. And perhaps by now, we have convinced you that it is indeed very important to check thyroid function if women present to you with infertility because of the physiological changes that we mentioned a while ago. And how then do you treat patients, particularly those with hypothyroidism, which will present to you, of course, with infertility? Levothyroxine is the only preparation of thyroid hormone that is recommended in the guideline, but the way to give them depends on the kind of patients that you have. If your patient has overt hypothyroidism, of course, it is recommended. No doubt about it, no question about it. When your patient has overt hypothyroidism, high TSH, low T4, T3, then give levothyroxine in order to render that patient euthyroid. But if the patient has subclinical hypothyroidism, meaning normal T4, normal T3, you only have elevated TSH, but they don't have any TPO antibody, there is insufficient evidence to show that levothyroxine treatment will improve outcomes, but it may be considered, particularly for patients who are really wanting to get pregnant. If the patient, however, is euthyroid, normal TSH, normal T4, T3, but they have TPO antibodies, then if they are euthyroid, based on studies, there is insufficient evidence to show that the outcome will actually be improved by giving levothyroxine if they are euthyroid. So quite easy to remember, if they're euthyroid, their normal thyroid function, then why do you need to give thyroid hormone treatment for these patients? This is now the most recent proposed algorithm for the clinical approach for thyroid disorders, just published 2 months ago, or earlier part rather of this year, January. So again, in women of infertile couples, part of the recommendation is to measure their TSH and thyroid antibodies, particularly your TPO. You can have three categories of your TSH. One wherein TSH is above normal, and that's probably hypothyroid. Within the normal range, euthyroid, and suppressed TSH, hyperthyroid. If they are hyperthyroid or suppressed TSH, check their T4 and T3. If they are both elevated, then you have an overt hyperthyroid patient, which must be treated with antithyroid drugs or surgery, and this will now render the patient euthyroid to improve fertility rates. If the patient's TSH is suppressed on the background of normal T4 and T3, that means subclinical hyperthyroidism, you must check your TSH after your treatment for these patients in order to of course, in order for you to check if there's a need for you to treat these patients. Ovarian hyperstimulation will be one of the very important maneuvers that will be very important to decide whether you will need to give treatment for these patients or not. On the other extreme, if the TSH is high, more than 4, then this patient is hypothyroid, and in the background of an infertile couple, it is recommended to start levothyroxine treatment after the ovarian hyperstimulation or even your assisted reproductive techniques. And you might need to follow up these patients to ensure that they are euthyroid with a repeat of your TSH every 4 weeks. Let's go to the middle part. The middle part, of course, is the euthyroid range. They have normal thyroid function. In the absence of thyroid or TPO antibodies, no further treatment may be needed. But in the presence of thyroid antibodies, particularly if the pregnant woman is desirous of pregnancy, you need to follow them up every 4 weeks. And if at one point the TSH elevates because of the presence of the antibodies, which may destroy the thyroid tissue and eventually make the patient hypothyroid, by that time the TSH goes up, then it is at this time that it is recommended to start levothyroxine treatment to render the patient's euthyroid. And so, my dear colleagues, with this second presentation, I hope that I was able to complement the first presentation of Dr. Alenzuela. And let me summarize by giving you 3 points. That thyroid hormones indeed participate in the regulation of ovarian function, and that thyroid disorders affect fertility adversely by their effects not just on the reproductive hormones but also on the menstrual flow, and as mentioned by Dr. Alenzuela, by in almost all aspects of the reproductive axis. And finally, prompt identification and appropriate management of thyroid disorders, be it hyperthyroidism or hypothyroidism, are necessary in order to improve fertility rates among women. Thank you very much.
Thank you, Dr. Nicodemus. The forum is now open for your questions and comments. So we have here 4 questions. For the first one, with regards bromocriptine treatment, how long does the patient need to take this treatment?
So that's for hyperprolactinemia. Usually 75% of patients will respond in 8 to 12 weeks. Some will respond in 8 weeks, but there are those who will take at least a year. So 75% on the average, 8 to 12 weeks.
Okay, thank you, Dr. Alenzuela. For the second question from Dr. Castillo, for subclinical hypothyroidism, how do we give thyroid hormone, and how long should they be taken by the patient?
Okay, as I mentioned a while ago, for subclinical hypothyroidism, it's not routine to give levothyroxine treatment, but however, the next thing that you must check would be the presence of the TPO antibodies. If the TPO antibodies are negative, we would prefer to observe and just repeat the thyroid function every 3 to 6 months. But if you have TPO antibodies that are present, then these patients are high risk for developing overt hypothyroidism in the future. And if this couple, particularly the woman, is desirous of pregnancy, then it is recommended to give low doses of your levothyroxine, even as low as 25 micrograms per day. And after about 4 weeks, it is recommended that we do a repeat of our TSH in order to make sure that it stays within the lower limit of normal, the lower half of normal rather, in order to render that particular woman with euthyroid and with better chances of fertility.
Okay, thank you, Dr. Nicodemus. From Dr. Mendoza, if we have a hypothyroid patient who becomes euthyroid with treatment and then wants to become pregnant, is it necessary to increase levothyroxine intake few months before conception? How about in her second, third trimester and the postpartum period?
Okay, I'm assuming that the levothyroxine was given prior to conception because of hypothyroidism. And in such cases, if the patient was indeed hypothyroid prior to pregnancy, then it is imperative that we continue levothyroxine and in fact even increase the dose by 20 to 30% during the first prenatal checkup, and adjust this depending on the TSH, which should be measured every 4 weeks during the first half of pregnancy. and again with the aim of bringing down the TSH in the lower half of the trimester-specific reference range for pregnant women. And we should maintain that and monitor that during the pregnancy if the patient is on levothyroxine.
For the next question from Dr. Manabat, for Dr. Alenzuela, would you recommend TSH to be less than 2.5 prior to conception, as is recommended by most obstetricians? Or do you agree with Dr. Nicodemus' slide where the cutoff is 4?
The most recent recommendation released the cutoff is 4 because we see now the evidence that thyroid hormone dysfunction will not just affect the HPO axis, but it will also affect the responsiveness of the uterus, even in the placenta. That's why thyroid disorders have also been implicated with preeclampsia, with accidents of pregnancy, even intrauterine growth retardation. In that study suggested by the American Thyroid Association, they have looked at a lot of women, and the recent suggestion is to increase that cutoff. I would agree with that cutoff.
Thank you, ma'am. From Dr. Garcia, if one is on levothyroxine treatment for hypothyroidism, how soon will she be ready for getting pregnant? And what is the interval to check again the thyroid hormones?
Okay, of course, it's important that before we advise a woman who has hypothyroidism to get pregnant, it's important that we render her euthyroid. By rendering her euthyroid, what I mean is that the TSH should be within the normal reference range prior to pregnancy. So we're talking here of a woman who has who's not pregnant yet. We have to ensure that the TSH values fall within the normal reference range of a non-pregnant person before we advise pregnancy. And then as soon as we are able to achieve that, then it's safe to advise these women to be pregnant. But then again, advise them that as soon as they are positive with pregnancy test, they come back to you for possible increase in the dose of the levothyroxine.
Yes, Dr. Nicodemus. As a follow-up from Dr. Mendoza, the initial patient who was hypothyroid and given levothyroxine, the patient is status post total thyroidectomy. So she was inquiring regarding adjustment of levothyroxine preconception and then during the pregnancy.
Thank you for the clarification, Dr. Mendoza. Now that you've mentioned that this patient is post-thyroidectomy, therefore, indeed, the patient is hypothyroid, and we need to, one, maintain the levothyroxine prior to pregnancy to ensure that the TSH is within the normal reference range. And number two, once the patient is already pregnant, how do you adjust? As I have mentioned, you adjust it by 20 to 30%, but that's too vague. So how do we do that practically? The recommendation is to add 2 additional days of the dose of the medication. So if your patient is actually taking 100 micrograms, say for example, Monday to Sunday, then add another 2 doses, perhaps one on Wednesday, she will have to take 2 tablets, and then on Sunday, 2 tablets. That's one easy way of trying to adjust the levothyroxine dose, although there's another technique that was also shown in studies to also be helpful, and this will be by increasing the daily dose, but this would now be based on the TSH. Either you increase it by 25 micrograms or 50 micrograms per day, as long in order for you to achieve the TSH within the lower half of the trimester specific reference range. And that means you will have to repeat TSH initially, perhaps every 4 to 6 weeks during the first half of pregnancy, and then once before on the second half of pregnancy.
Thank you, sir. For Dr. Alenzuela, do we have evidence if isolated hypothyroxinemia affects fertility?
Isolated hyperthyroxinemia is going to be difficult because, as we have shown, there is always an interaction between all of the other things, specifically in the higher levels. They cannot just pinpoint if it is just purely secondary to the thyroid hormone increase, because as we have mentioned, thyroid hormone influences estrogen, it influences FSH and LH. There's always a cross reaction because biochemically there's similarity to all of this. That's why the recent suggestion now, and I would agree with Dr. Nicodemus, that if a woman is infertile, regardless whether she has regular menstruation, the evidence of clinical, subclinical thyroid disease must be elucidated so that pregnancy outcome will be at best. Number one, so that infertility treatment will be good. Number two, there are women who will have ovarian hyperstimulation if they have subclinical hyperthyroidism. And if they do become pregnant, they can end up with abortion, they can end up with other poor pregnancy outcomes. So it is best that all of this be investigated. So
Thank
you
you,
have to
ma'am.
be friends with your endocrinologist.
Agree.
Thank you, ma'am. In the next question from Dr. Saliba, in managing PCOS with hypothyroidism, what would be the timing for metformin and thyroid medication?
Okay, I'll answer the part on the levothyroxine, and then I'll ask Dr. Alenzuela about the metformin. For the levothyroxine, it is best administered on an empty stomach because of the very large interaction with food. So what we would do, what we would recommend is to take levothyroxine at least an hour before the first meal in the morning. But then for people who forget to take this tablet before the breakfast meal, another study was able to show that you may take it at bedtime, provided that there is a 3-hour difference between the last meal and the bedtime. So you can take it safely 3 hours after your last meal in the evening before you go to bed. So, but then again, preferably we would still want the patient to take it in the morning, at least an hour or 30 minutes before the first meal of the day.
And Dr. Alenzuela for
So,
metformin?
as far as metformin is concerned, okay, if you have a patient who has PCOS and who has hypothyroidism, I think you should make sure that you are dealing with polycystic ovarian syndrome. Remember, patients who have a thyroid dysfunction may have polycystic appearing ovaries, and she would have also oligomenorrhea. And in the presence of a thyroid disorder, we rule out PCOS first. You try to treat her first because she probably has hypothyroidism. What is now the role of metformin for patients who have hypothyroidism? If she has evidence of insulin insensitivity, if she has evidence like if there's acanthosis nigricans or there is a glucose impairment, then this is probably the time when you can give metformin. So that's my suggestion. That's why we said PCOS is a diagnosis of exclusion. You have to rule out. The requirement for the diagnosis of PCOS is oligo or anovulation. Second would be hyperandrogenism. And the third would be polycystic appearing ovaries. And all of this we see in hyperthyroidism. So if you have 3 out of 3 and she has hyperthyroidism or hypothyroid disease, the disease is hypo, is the thyroid disease, not PCOS. Agree tayo doon.
Okay, thank you, ma'am. For the next question, without the benefit of TPO antibody, a patient with subclinical hypothyroidism, is there a target TSH to go for to assume levothyroxine replacement?
Okay, that is quite a hard decision to make, Arnel, because nowadays the decision to treat with levothyroxine in subclinical hypothyroidism is hinged on the positivity of the TPO antibody. If it is unknown, if that status is unknown, it's hard to decide whether you will need to give these patients levothyroxine, particularly if they are aiming for fertility, because in the fertility treatment and in the workup, TPO is really included. I guess that's my answer. It's difficult to start to decide in the absence of TPO antibody. And the good thing is TPO antibody now is really common as a test that can be done in tertiary centers. and can be done, particularly in the workup of infertility.
Thank you, sir. From Dr. Garcia, again for Dr. Nicodemus, how often should we check for TSH to check if your patient has become euthyroid and safe to start fertility ovarian stimulation?
Okay, thank you very much, Dr. Garcia, for your question. Of course, since we're talking here of a non-pregnant person, the recommendation is just to do TSH in order to assess whether you are giving the proper dose of your levothyroxine between 6 to 8 weeks, around 6 to 8 weeks after you have adjusted your dose of levothyroxine in order to assess whether you're giving the proper dose. And then if your patient has been on that particular dose and for two determinations, the TSH has been within the normal reference range, then you may decrease the frequency of monitoring to every 3 to 6 months.
Thank you, sir. So, a question from Dr. Domingo. Do we request for TSH, FT4, and FT3, or TSH, T4, or T3? Lahat po ba ito ang ito-test, sir?
Okay. Of course, sabi nga natin, di ba, the most sensitive would still be TSH sana, no? But then again, if you have a patient with abnormal TSH, in order for you to know if it is overt or subclinical, then you will have to also request for an free T4 and a T3. And so ako, what I would normally do is to request all three at once. TSH, free T4, and T3. Why not a free T3? Because as we know, the binding globulin for your T3 and the binding part is really very small. So it really doesn't matter. So and it's even more expensive to request for a free T3 than a total T3. So what is recommended even internationally is just order for a total T3, a free T4, and a TSH.
So we'll be just entertaining two more questions. Is that okay for everyone? So the next question would be from Dr. Lopez. For a post-thyroidectomy status post-RAI therapy patient, are there any parameters to check or the levels of thyroid hormones to achieve pre-pregnancy and during prenatal status?
Okay,
So
so
again,
dobling nangyari dito, no? Na thyroidectomy na RAI pa, no? So I would suspect that baka this patient might be thyroid cancer, no? Or kung hindi man, merong graves na hindi talaga na-control. But again, since we're talking here of a non-pregnant person, a non-pregnant woman, our goal would be to render this particular person or patient euthyroid by giving levothyroxine, assessing the TSH, ensuring that the TSH is within the normal reference range. So it's just as simple as that. You just have to make the TSH go within the normal reference range for the non-pregnant person. And that would already be good to advise this patient to become pregnant.
and for our last question from Dr. Candelario, a patient who presents with the PCOD, or perhaps this is PCOS, and has hypothyroidism. So this patient has to be treated first with levothyroxine. And if after 6 months patient is still anovulatory, what would be the next approach?
You have to check whether anovulatory still, if the woman is euthyroid already and she's still anovulatory, then that is a possibility of a polycystic ovarian syndrome. But if after treatment she is still not euthyroid, then again continue until she becomes euthyroid.
Okay, thank you for our attendees in posting all those interesting questions. And again, thank you, Dr. Nicodemus and Dr. Valenzuela, for answering the questions. So that ends our open forum. And again, we would like to thank our sponsor, Merck, and our technical partners, Telemedicine Network of the Philippines, for their invaluable contribution in making this webinar trilogy possible. And there were comments in the chat box about the subsequent sessions we will have. So we hope you can join us on Wednesday to talk about the role of maternal thyroid status on pregnancy outcomes. And on Friday, we will discuss the short and long-term effects of thyroid dysfunction in the newborn. And as a reminder, you just need to register once. So you've registered for this webinar already. You'll just need to use the same link provided in your email by the PTA Secretariat. No need to re-register for the subsequent sessions. Okay, thank you again, and we hope to see you on Wednesday and Thursday.
Thank you. Bye.
Thank
Thank
you.
you. Bye. Thank you, everyone. Thank you.
Okay. Thank you, Doctora. Thank you,
Okay. Thank
Nemi.
you. Bye.
Excellent discussions. Very good.
Thank you. Exit na, pwede?
Pwede na
Bye.
po, Doctora. Bye-bye. Bye, Dr. Nemi. Thank you, Arnel. Bye-bye.
Thanks, everyone.
Thank you po. Thank you. Doc Jeff?
Yes?
Sir, ano nangyari kanina?
Naputol ka.
Saan part po naputol?
Sa introduction.
Introduction po ni Dr. Valenzuela o Dr. Nicodemus?
Patapos na yung kay Dr. Valenzuela, tapos patapos na rin yung kay Dr. Nicodemus.
So naputol ng mga patapos na, sir. Pero yung
Yes,
first parts, nag-ano naman.
oo.
Para nagkaroon ng naputol